It is my honor and pleasure to introduce our first speaker, who is a man, for most of us in the youth mental health field, this man really needs no introduction. Dr. Tom Insel has lived what I consider a good life, and that's a good life. Living a good life is different from living the good life, right? A good life is a life that is lived with a cause and a purpose beyond your life that will have a ripple effect. And the work of Dr. Tom Insel will have a ripple effect on all of us, our children and our grandchildren, because he has dedicated his life to the mental health of our nation. He is known as our nation's psychiatrist. He ran the National Institutes for Mental Health, and he also more recently was appointed as a special advisor to Governor Gavin Newsom on mental health. And we came to know him as the mental health czar. And, you know, being the nation's psychiatrist is really, you know, psychiatrists are about healing. And that is appropriate because his most recent book, Healing, moving from mental illness to mental wellness. So it is my honor and pleasure to introduce our dear friend, our nation's psychiatrist, Dr. Tom Insel.
Well, thank you, Lori, for that very generous introduction. I've heard this before, that I'm the nation's psychiatrist, which is a little strange because I don't actually practice. So I can hardly be considered someone who has the skills of so many people who are in the trenches doing this every day. But I'm here because I'm really intrigued by the AIM mission, which Lori just mentioned, was this very ambitious effort to move from research to practice, to actually implement the things we know. And I'll start with a bit of a story about the latter phase of when I was serving as director of the National Institute of Mental Health, which is a research agency. It's like other parts of the National Institutes of Health. The job is largely to support the science across the nation's and sometimes the world's academic centers to get, getting a little feedback here, to get the best information we can about human health and human illness. When you run an institute like that, you're living on public dollars. It's all taxpayer supported. So part of what you do is you, as a director, just like Tony Fauci or Francis Collins or any of us, we spend a fair amount of time talking to the public and listening as well as to get ideas and to get an understanding. I was doing that, I think it was about 2014, 2015, here on the West Coast, in a group very much like this, made up largely of family members, people with lived experience. And at that point, I was running the president's brain initiative, and so we had these spectacular stories to tell. Beautiful videos of pathways in the brain, lots of information about new molecular targets that we were pursuing, fantastic studies from the whole world of neuroscience, molecular cellular neuroscience, and all the new tools we had to use in that domain. At the end of the talk, the first question was from a guy in the back row. It always happens that somebody's in the back row. He jumped up, grabbed the microphone, and he said, "You know, you just don't get it." Hello? And he said, "Yeah." He said, "My son is 23. He has schizophrenia. He's been hospitalized 5 times. He's been in jail twice. He's made a suicide attempt, and he's currently homeless. Our house is on fire, and you're talking about the chemistry of the paint." And my first response was to say, wait, you know, science takes time. It's a marathon. It's not a sprint. You know, give us some time here to really understand these problems before we try to solve them. But I walked away from that because, as I said, the idea of those sessions is to listen as well as to explain. And I I had to really hear what he said. It took a while to sink in, and I began to realize he had a point, that we're in a crisis in this country around mental health, and we're not addressing it either scientifically, philanthropically, or in terms of our services with the urgency that it deserves. And that's what I want to talk about this morning, because part of what I was struggling with is why that would be. So let's take a bit of a journey to go through that. It's the journey that I went on. I left the federal government in 2015. I moved to the tech sector in Silicon Valley, worked at Google for some time to develop a mental health program under a new company we spun out from Alphabet called Verily. Then went on to co-found a number of other startups, all with this goal of trying to figure out, how do we innovate? How do we create the solutions that can begin to solve this crisis? So that's the quick story that we'll go through with these slides. Disclosures are not important because I won't be talking about any of the products that we've developed, but here's basically the problem. As I said, fantastic progress in neuroscience, behavioral science, and technology. We have, and this is a really important message for everybody here, we have good stuff. We have good interventions, some of which are medical, some psychological. There are others as well, which we'll talk about briefly, but we have good stuff to offer. More people getting more treatment than ever before, and yet the outcomes are worse. That's the conundrum that I couldn't figure out as I was leaving the government, or as I listened to this guy telling me the house was on fire. And it was really the driving force for writing the book, which Lori mentioned before. What's the evidence for being in a crisis? Well, the fact is there's no reduction in morbidity or mortality, that is in disability or death, over the last 4 decades. If you look at how we measure disability, something called disability adjusted life years, it's a kind of unfortunate term, it almost sounds like a kind of economics, but it's a way of trying to capture people being unable to work, unable to function, as well as early mortality into one number. And when you do that, neuropsychiatric disorders, brain disorders, have become the #1 source of disability in the United States, and it's not surprising. They start early, and they lead to unemployment, homelessness, incarceration. People with these illnesses will die 15 to 23 years early, and of course, huge problems around people becoming destitute with these. Mortality isn't much better. Now, there's a great story to tell in medicine about places where we have been able to actually reduce mortality in a profound way, and I listed them here: stroke, heart disease, AIDS, and particularly childhood leukemia, where when I was a medical student, 90% fatal, today 90% cured. That's not the story we can tell in the mental health space. Suicide's gone up about 30% over the last 20 years, 22 years since the turn of the century. It's true that the suicide rate has come down slightly in the last 2 or 3 years, although for some groups it's actually continued to go up, particularly for adolescents of color. It's gone from about 24 per 100,000 to 27 per 100,000 in 2019, 2020, 2021, across the pandemic. So continuing challenge around mortality, and of course that's even more true when you look at drug overdoses. Data that was captured by the New York Times now, more than 2 years ago, showing that already at that point, with about 70,000 deaths per year, drug overdoses had surpassed the peak year for car crashes, HIV deaths, gun deaths, and of course since then we know the rate has just skyrocketed. The most recent data from the CDC show that we have 100,000 deaths per year, more than that, from drug overdoses. It's a stunning number. We don't know how many of those are actually the result of accidents and how many are potentially intentional. They could be essentially suicides. And so increasingly we talk about deaths of despair, this idea that there are now deaths from suicide, drug overdoses, and alcohol-related deaths that basically are the result of people becoming hopeless, giving up, and generally getting caught up in this cycle of self-destruction. Those numbers are really concerning. This was captured by Ann Case and Angus Deaton. They won the Nobel Prize in 2015 for this story of trying to describe what had happened in America with this increasing deaths of despair. By the way, these numbers are not like this in any other country, according to Case and Deaton. This is an American phenomenon, most likely concentrated in the group of white people without a college education. These are the ones who really drive some of these numbers. And you can see that overall, though the numbers aren't perfect because we've changed the goalposts a little bit, the numbers have increased almost fourfold since 2000. We're of course still in this COVID pandemic, and we talk a lot about this as the biggest public health crisis in 100 years, which in some ways it is. We have now a million deaths, but these data were taken from earlier in the month, and you can see that we're just about at 1 million deaths there. But it's important to note, particularly for this meeting today, where we're going to focus on youth mental health, that COVID, all those deaths largely focus on people over the age of 64, certainly over the age of 50. And if one concentrates on people under the age of 30, the total is about 7,000 deaths over the last 2 years and 3 months, up until April 13th. And just, again, for reference, in just the year 2020, we had 15,000 suicides for people under the age of 34, and almost 17,000 overdose deaths in 2019 before the big surge. So one would assume those numbers haven't yet been broken out by CDC by age group, but one would assume that that number is closer to 20,000 today. So putting those two numbers together, roughly 35,000 deaths per year relative to 7,000 from COVID over the last 2 years and 4 months. So it's interesting that we're so focused on COVID as a public health crisis of the century, and yet we're not talking enough about the mental health crisis for young people, which is 5 times worse in terms of mortality. So why are we in this? For the book, I spent a couple of years traveling the country and actually the world, asking people just this question: how did this happen? How did we get here? And the answers I got mostly were, well, the problem is we don't know enough. We don't have enough people in the workforce. We don't have good treatments. We don't spend enough. And almost everybody said, oh, the problem is stigma. And I want to start by saying that the more I dug into each of those explanations, the more I was unconvinced that they explain the morbidity and mortality, the disability and death problem, particularly for young people with mental illness. Look, we never know enough, but that hasn't kept us from reducing the death rate from AIDS, from childhood leukemia, from cardiovascular disease. Therapists, we have almost 700,000, according to SAMHSA, the Substance Abuse Mental Health Services Administration, the federal agency that's responsible for this stuff. 700,000, that's like relative to 200,000 primary care providers, 200,000 dentists. 700,000, that's a lot of people. So the question you have to ask is, with all that big of a workforce, why can't any of us find a therapist? You don't have effective treatments? Absolutely not. You know, I hear this over and over again, that we don't have anything to offer. And if there's nothing else you hear from me, know that we do have effective treatments across the board for virtually every mental health disorder. And the indictment of us is that we haven't delivered on them, but they're there, often hiding in plain sight. We don't spend enough. Well, we're spending 52% more than we were 7 years ago. It's in the $250 billion range. The problem is we're probably spending too much in all the wrong places. We're paying a lot for the most expensive intensive care and not paying for the things that often work. Stigma is the issue I often come back to because I dislike that word so profoundly. It's a victim word. It's a word that breeds passivity. It doesn't breed change. So I want to increasingly shift us from talking about stigma to talking about discrimination, to talking about civil rights, to putting this in the context of social justice. This isn't just people don't like us. Stigma doesn't capture what we really need to think about if we want to make a change, if we want to begin to bend the curve here. So if those aren't the answers, what are? Well, I'll go take you very quickly because we don't want to take too much time with this. I really want to talk about solutions, not problems, but I do think you need to at least hear what I heard as I started to travel the globe on this. First of all, we've got a capacity problem. We've got a problem with engagement. We've got a problem with quality, with accountability, and we've got a problem with equity. And I'll take you through each of those. I want to unpack them very quickly so you get a sense of what is the problem that we need to solve. And then I think when we're really clear on that problem set, we can start to put together the solutions. Spoiler alert, we have solutions for every part of this. That's the hopeful message, and we'll end up there. Let's talk about capacity. Often, and all of you know that we had this phenomenon of deinstitutionalization. Closed the state hospitals where we had 600,000 beds, and we were going to replace them with a community mental health center. The centers that never happened. People ended up being homeless, ultimately being incarcerated. So at the same time that the blue line, the state hospital capacity line, goes down 95%, you can see there's a sort of, what is that, about a 50-fold increase in jails and prisons. And of course, the criminal justice system, jails and prisons have become the de facto mental health institutions in this country. LA County Jail, Cook County Jail, those are the largest mental health institutions in the United States today. What an indictment of this problem around capacity. Of course, we do not want to simply put in more beds, and we don't want to rebuild the asylum system, but that's part of what we need. We need community mental health centers, we need a whole range of resources, but some people do need to be in a safe institutional environment that's committed to health and not to punishment. Criminal justice system is not the right place. Engagement. We've got about 14 million people with serious mental illness. That's the psychotic illnesses, severe eating disorders, severe PTSD, sometimes severe OCD, people who are disabled by mental illness. And when you look at the treatments they get, what you find is that only about 40% are in care. And of those, about 40% getting what the NIMH called minimally adequate care, that is care with a scientific basis. In that group, about a third get full benefit, a third not so much, a third not at all. The 40-40-33 rule is how I describe that. It's not a great expression perhaps, but it's there to remind us that we're only working with about 5 to 6 or 7% of the population getting the best care that we have. And it's interesting to me because one of the things I kept hearing from my colleagues who were psychiatrists or nurse practitioners or psychologists is they'd say, hey, I don't get your question because you tell us that we have a crisis and we're failing, but I'm doing better than I was 20 years ago. People I see are getting better. And I think that's absolutely true. But those folks are seeing this tiny fraction of the population. And what's driving the fact that we don't have changes in the suicide rate, we don't have changes in the disability rate, is that most people never get into care. 65% the people who die by suicide were not in the healthcare system, the behavioral healthcare system. So you don't see them until they're dead. You can't fix this only by trying to fix the healthcare system. So getting the engagement problem solved is super important. Quality. When I was at NIMH, we asked Myrna Weissman to try to answer this question. She's an epidemiologist and social worker at Columbia University, very smart. And she had developed a new form of psychotherapy called interpersonal psychotherapy. And she was very frustrated that she couldn't get people to use it because the data were very clear that it really worked. And this is really to the AIM issue of how do you close this gap between the things that work and the things we do, what we know and what we do. And so she went out and looked at all the training programs for psychiatrists, psychologists, social workers, family counselors, the whole range of those 700,000 people in the workforce. What are they trained to do? And much to her amazement, in the graduate programs, in the training programs, at least for psychologists and social workers, more than half were never exposed to any of the psychotherapies that actually have a scientific basis. Now that's a real problem. You wouldn't see that in the treatment of cancer, heart disease, AIDS, any of those other places we've been talking about. But here we have a real gap in quality, partly because of the training being out of sync with the science. Accountability, big issue here. Again, in contrast to the rest of medicine, we don't measure. There are no biomarkers, and there's a lack of even capturing patient-reported outcomes in any standard or objective way. It's called measurement-based care, is kind of the term of art that we're aiming for, but only about 20%, maybe less than 20% of providers actually measure in some standard format, collect the data, and create the kind of learning system that we need. And finally, lack of equity. I show this because we're in the middle of a really important, long overdue reckoning about racial injustice and the fact that on so many of these measures, life expectancy, employment, use of force by police, incarceration, people of color are underserved. They're worse off. But I want you to know that irrespective of race or ethnicity, people with serious mental illness are truly the untouchables in this country. That on every one of those measures, they are the worse off. And for those people with serious mental illness who also are people of color, that's really part of the driver of those orange bars. They're really, that's the double jeopardy problem. So it's time, I think, for us to begin to have a reckoning about that population, 14 million people who really are, in some ways, the absolute underclass in this country only because they have a brain disorder. What an indictment, what a statement. To think that people end up incarcerated, shot by police, unemployed, and dying 15, 18 years early simply because they have a brain disorder. That's what I mean, that this is a crisis of care. It's not a crisis driven by an increase in prevalence. It's a crisis driven by our failure to help the people who can't help themselves. So there are solutions, and that's what I want to spend the rest of the time talking about and very quickly go through what we can do because we know what to do. Some of them come from the world of technology, and obviously I'm biased. That's a world that I live in, but I do think that we're in the 21st century at a time when we have discovered new ways to deliver goods and services, and it's not any less true for healthcare than any other area. These are the problems. What I want to argue is that we have some tech solutions. These aren't cures, they're not magic bullets, but there are things we can do with software and hardware that can help. Certainly, from the lack of capacity, one thing that's been, for me, remarkable is the huge investment that's already taking place from the venture world to try to innovate in this space. $5.1 billion last year from venture capital to try to fix the behavioral health access, quality, accountability problems. 5.1 billion, again, to put it in reference, my old budget at NIMH was about 1.5 billion a year, 70% of that going to grants that were already funded, so it was paying the out years of 5-year grants. So we had about maybe $300, $400 million a year. So less than 1/10 of what's going in from the private sector right now. That's very hopeful, I think, because, well, there'll be lots of shots on goal, lots of things that won't work. This is how we begin. The process of building capacity is by beginning to make those investments. We'll talk a little bit about federal investments and public sector investments as well. The engagement, this is where tech really shines. The problem, of course, with tech is it's way too engaging. It's addictive. Whether it's video games or social media, they know how to hook people in a way that the mental health care system has miserably failed. So creating the kinds of person-centered online care that you can do with technology is a way of really closing that gap, meeting people where they are, and making sure that it's not a 40% engagement, but more like an 80 to 90% engagement. We can fix quality through training, and that can be done online, it can be done at scale. There are ways of coordinating care and beating back the fragmentation, providing more integrated services with software. There's a bunch of things we can do here. Accountability is about measurement and figuring out how to create the kinds of measurements that matter. Moving to a system where we don't pay for fee for service as much as paying for outcomes, paying for actually getting people well. Today we pay for people being sick. Not so surprising, if that's what you pay for, that we get the sick care system we have. If we want to move to a healthcare system, it means beginning to pay for people getting well. And finally, on equity, we'll talk more about this in just a moment. There's a whole shift away from the model that we've had to a model that's more about recovery. One way to think about this, and it's not the only way, but just to give you a sense of where technology fits in, because we don't have time to go through the particular solutions, but there's a whole field that's creating new opportunities. Around engagement, it's the chance to actually begin to use software to bring people in new ways. And some of that is just providing the standard psychological treatments we have, or even medical treatments, and making them easier to access. Some of it is changing the workforce by bringing in peers and allowing them to empower people to get the services that they need. There's a whole bunch of things that can be done. I call this democratizing care. So solving the access problem and the engagement problem by creating care that meets people where they are and gives them something that's more the way they want it. It's so clear that particularly for young people, for people under the age of 25, the system that we built, what we are trying to sell is not what they want to buy. And if we really think that that kind of brick and mortar 50-minute hour once a week system that has existed for 40 years is going to serve this next generation, we're going to see those numbers go from 40% engagement to 20 to 10%. It's just not what people want anymore. Great example of this. I was just so stunned by this. We're in the middle of a national conversation about new crisis services with 988, which is a new number, without ever thinking that young people do not use their phones to call, particularly in a crisis. They're not going to use a phone to make a phone call. It's got to be chat, it's got to be text, we got to rethink our services and rethink our interventions to meet people where they are and to give them services in the way that they want. Care management, obviously you can do the coordination, the data capture, all of that is what software is made to do. And then this whole new area of how we measure passively, continuously, ecologically, by using wearables and phones and other kinds of measures, like instead of asking people, how's your sleep, actually monitoring sleep. You know, my 13-year-old grandson has a little wearable that he has on, and every morning he can tell me exactly not only how he slept, but like how much delta sleep he had, or slow wave sleep, how much REM sleep he had, how many hours. It's pretty stunning. Why aren't we using that in the healthcare system? Of course, the real value of this is that we build this kind of flywheel, that all of these kinds of innovations begin to serve what we call a learning healthcare system. We get better as we go. And that is very much the culture of the tech world. So increasingly, you know, when I talk about what tech can do for mental health to solve the mental health crisis, it's actually not about the software and the hardware. It's about how tech innovation works, how tech companies operate, because they're so focused on consumer-centered, or what they call UX design. They're really good at capturing data and learning in real time to improve what they do. And when I was at Google, we would change, believe it or not, we would change the Google search algorithm every hour. It's stunning. And that would be based on data from 10, 50, 100 million people that we would collect in the course of a few hours. That's what makes it work so well. That's how it gets to be so effective. That's not what we do in mental health care, where we don't even measure outcomes. So we've got a lot to learn from that, getting the kind of feedback that helps us improve. But hey, tech is a piece of this. It's not more than a piece. I often say what we need is both high tech and high touch. So I want to capture some of the other issues. Right now, we're in a moment where for the first time in 41 years, 42 years, the federal government and the White House in particular have decided that mental health is important, particularly youth mental health. So it fits really well with the AIM mission. It's kind of amazing at the State of the Union when President Biden said, let's take on mental health. We haven't heard that in a while. And they put out the same day this unity agenda, which had all of this kind of very exciting set of policy changes that had to do with some of the things we've just been talking about, building out the capacity, connecting to care, improving quality, and creating better environments, and moving upstream. Super important. How that'll play out remains to be seen. You know, the executive branch proposes, Congress disposes. We're going to have to see what actually comes out from appropriations, but important to watch this. One place where the federal government's already gone is to put in the new crisis line 988. It's required by July 16th of this year, so within the next couple of months. Every jurisdiction in the United States has to have this line in place of using 911 or the Suicide Prevention Lifeline number, the 10-digit number. It's important because it could solve many of the issues we're facing that I've talked about, like ending up in jail instead of the healthcare system, having crowding in the emergency rooms. We haven't talked about that huge issue. Unfortunate, really tragic interactions with criminal justice. A lot of that could be solved by creating a different crisis response system, especially one that has this whole continuum. You've got a new number to call. It's not for police, it's not for fire, it's for a mobile crisis van, which brings you not to jail or not to an emergency room, but to a psych drop-off center. This is kind of what this looks like in Tucson and Phoenix and a few places that have built this out, and it works. It's amazing. It actually is not that hard to do. It requires having, though, more than the new number, it requires having an entire continuum. Someone to call, someone to come, someplace to go. When you do that, you can drive down those numbers for incarceration, you drive down the amount of ER boarding or crowding, and you certainly drive down the tragic interactions with criminal justice. Creating new ways of paying is super important as well, and we're getting good opportunities to do that with this new federal program, which is sort of like the community mental health centers of the 1960s, but taking a lot of lessons learned for a whole new system. There are 430 of these across the country that have already been funded and are operating, and they're taking on serious mental illness in a whole new way with what's called whole person care. They're paying for things that in the past have been hard to get Medicaid or Medicare to pay for. We're moving upstream increasingly to think about prevention, and in California we have this new initiative, the Child and Youth Behavioral Health Initiative, a $4.4 billion commitment to youth mental health. Wow. I mean, this is, by my calculations, 100 times bigger than any previous commitment on this topic. Early days, recently funded. We're still going to have to figure out all the different moving parts and how they'll work and how to execute on this, but it's incredibly promising. I want to end by talking about one other piece of this, which is a different model, a different way of thinking about the problem. And that's this term recovery. It's a term, that's in some ways freighted with a lot of other stuff that goes around it. Recovery is kind of a 12-step issue. I'm talking about it in a different sense. Recovery in the mental health space really has to do with giving people a chance to thrive. And it's most of all maybe important to remember that, well, we've been talking about mental health, and what I've been saying up until now is, how do we fix the mental health care system? Mental health is a lot more than mental health care. And this was, I think, the biggest insight for me in working on this book, was to begin to realize that if what we really cared about was improving mental health, we had to get beyond thinking about mental health care. Great example of this is shown with this map of the metro system, in which case, even though you're 17 miles apart, you've got a 20-year difference in longevity. And that's not due to just better health care. It's due to social factors, health behaviors. Strange thing here is we're spending $4 trillion a year on care, and yet on these other pieces that have probably more to do with health, you have to have a bake sale. It's all about philanthropy. It's really difficult to get funded. So to finish up, I mean, for me, a lot of what I began to understand was that we had to get away from a focus simply on crisis and on symptoms to think more broadly. I was in LA talking to a psychiatrist who works on Skid Row, and he said, "You want to understand recovery?" He said, "Man, it's so simple. It's just the 3 Ps. And I thought, well, you got Prozac, you got Paxil, what else you got? And he said, no, it's people, place, and purpose. People, place, and purpose. All of which have been harder to do in the last few years with the pandemic. The point being that, yes, these are medical problems, right? These are brain disorders. These are illnesses. Just like any other illnesses, they need to have the same kind of reimbursement, the same kind of rigor, the same kind of science, the same kind of standards. The problems are medical. The solutions are much more. The solutions have to include social, environmental, political. They're the 3 Ps. So recovery says, let's get beyond the crisis. Let's get beyond just thinking about symptoms. Let's redefine care in a way that gives us a much more holistic approach, begins to ask, can we help people to get the social support? Can we help them to get the sanctuary they need, the time and place to recover? Can we give them a purpose? Can we help them find a reason to live, a reason to thrive, a reason to recover? I think we can. I think every one of those pieces is actually already in place. We have clubhouses, we have ACT teams, we have all kinds of groups that allow people to get the social support and all 3 of the Ps, but we don't pay for them. They're not part of health care. You can't use Medicaid to pay for a clubhouse. All of that, of course, we can change, and we need to be thinking differently about this if we want to be able to actually solve this crisis. So to finish up, this was the conundrum we started with. Why, with all this progress, are outcomes no better? It's actually what AIM is all about in the youth mental health space. And the answer is, it's not just healthcare. It's these 3 Ps, people, place, and purpose. The problem is medical, but the solutions are social, they're environmental, and political. So what I'm suggesting is that what we really need is not just another app or another pill. What we need is a real movement for mental health. Healing was an attempt, a call to action. It's like an inconvenient truth to try to start that movement. All of the proceeds from healing go into a nonprofit called Mindsight News, which is a daily publication and a platform for really a national conversation about this. Mindsight News is available free to all of you. I hope you'll subscribe. And it's an opportunity really to begin to build this movement, which is going to require everybody in this room and another 100 million people along with you if we want to be successful. Thank you very much.